vaccination rates among those 12 and older, not just vaccination rates for adults, are important, particularly as we continue to reinforce the importance of keeping our children in school for in-person learning as much as possible and protecting everyone eligible for vaccination from this terrible virus. Now, as more Ohioans gain robust immunity through vaccination, what we're doing is reducing the opportunities for this virus to spread, mutate, and inflict serious medical harm. And we get closer to the day when this virus can no longer upend our lives. Today, I'm joined by the physicians who are the hospital zone leads for our state and have helped to guide our regional COVID-19 response in hospitals throughout this pandemic. First, representing the most southern portion of our state is Dr. Rick Lofgren, President and CEO of UC Health. Dr. Lofgren, can you tell me a little more about what hospitals in your zone are seeing at this time?
Thank you, Bruce. I would really just echo what you said about the state in general. We are seeing a decisive surge that started in the middle part of July. When you look at the trajectory about the rate of growth of the number of new cases that are requiring hospitalization, it parallels what we saw in the fall when we had the largest surge. To put in perspective, in the greater Cincinnati area, in the June and into early July, we were seeing about 40 to 50 people hospitalized in our region with COVID-19. Today, we have 363 people hospitalized and 118 of those in the ICUs. So this has been the same dramatic change that we've seen before. And obviously, we are reactivating all of the things that we've learned along the way over the last 18 months to prepare for the surge. That one of the things I would say is that the big surge that we saw in December and January in the greater Cincinnati area peaked around 800. That really did stretch our healthcare delivery system. Didn't quite break, but we definitely saw the push. I think what we're seeing now is the same sort of upsurge. We are concerned that we're pleased that we've learned a lot. We know how to are more effective in treating. The supplies that we have from PPE appear to be fine. We actually think we have adequate beds and we keep track of the ventilators. I can tell you, and you'll hear throughout the state, the issue is that we don't have and concerned about having adequate number of staff to take care of the patients if the surge continues. You know, the big surge last fall and into the winter, you know, the workforce here who were truly heroes rose to the occasion, working overtime and extending themselves and stretching themselves. And since that time, we've unfortunately lost people who are who opted out of the field. Plus, people are just tired, and really the ability to stretch is really taxed at this point in time. The other two things that I would just echo is that we're seeing definitely younger patients. We're seeing people who are hospitalized who are in their 20s and 30s who have no pre-existing medical conditions related to this Delta virus, as well as we're seeing in some pediatric cases as well. The vast majority of people are unvaccinated. We have seen patients hospitalized with what we call breakthrough, meaning that they were vaccinated, but they did acquire it. Most of those people have significant underlying immune deficiencies, which really speaks to the fact that the vast majority of people that are acquiring the disease to the point that they require hospitalization are in fact unvaccinated individuals.
Thank you. Thank you very much, Dr. Lofgren, for that update. Next, we're joined by Dr. Andy Thomas, the Chief Clinical Officer at the Ohio State University Wexner Medical Center. Dr. Thomas, what are you seeing among hospitals in the more central portion of our state?
Thank you for the question, Bruce. I would really echo a lot of what both you and Rick have just shared. We do zone-wide calls with over 40 hospitals and health systems across the three regions of the state that are in Zone 2. We do those every Monday, Wednesday, and Friday at 9 a.m. And we had cut down to once a week prior. We've had to increase the cadence of those, mainly because we were fielding all sorts of requests and concerns, everything from a hospital that had run out of BiPAP machines, a way to deliver oxygen to patients just short of being on a ventilator, and we needed to get them some supplies. Similar with high flow oxygen, when they had seen a rush of patients over a short period of time. We have one hospital that has taken their emergency preparedness tent out and are seeing their treat and release emergency department patients in a tent because their ER is so full of patients waiting for a bed. We had just today, one of our regional hospitals, it's a 19-bed emergency department. They had 11 patients boarding, waiting for an inpatient bed. Now, the good news is we have 40 hospitals and health systems in the zone. We were able to parcel out 2 or 3 of those patients to each of a number of hospitals that volunteered to take a couple extra. But I can tell you, in Central Ohio, the 3 large health systems, Mount Carmel, Ohio State, and Ohio Health, all of us are facing significant capacity challenges. We were busy with non-COVID patients prior to this, partly because people had put off care, partly because, frankly, people are showing up more acute or sicker than they have really ever in the past, I know, for here at Ohio State. So the lengths of stay for some of those patients are longer. But then to add COVID on top of that, your point earlier, Bruce, about 1 in 10 patients in the hospital in Ohio for any reason are there because they have COVID. To think just 30 days ago, it was 1 out of every 38 patients. That crowding out phenomenon in our ICUs going from 1 out of every 24 patients to 1 out of every 6 with COVID. It's going to eventually start to impact the ability of our systems to deliver routine care and have routine clinical operations. In fact, one of our major health systems, and this was in the news yesterday, has decided next week at 4 of their hospitals in the region, they're not going to be able to do elective cases, surgical cases. And we're not talking cosmetic things here. We're talking, medically necessary surgeries. Now, they could be delayed or postponed for a couple of weeks. But if those surgeries require an inpatient bed, they're postponing them. That's a pretty major change. And really, to Rick's point earlier, it feels like where we were in mid-December. It feels like where we hear hospitals in Florida have been, say, over the past 4 to 6 weeks, hospitals in other states. So it's quite concerning. Now, we have great partnerships. We're all collaborating and working well together. But this is going to be a difficult road if cases don't peak soon and hospitalizations peak soon.
Thank you very much, Dr. Thomas. Finally, I'm joined by Dr. Robert Wiley, Chief Medical Operations Officer at the Cleveland Clinic. Dr. Wiley, what are you seeing and hearing from hospitals in the northern portion of our state?
Thanks, Bruce, and certainly agree with the comments made by my colleagues in Zone 1 and Zone 2 in terms of the overall nature and your comments about the pandemic so far. Fortunately for Zone 1, the infection is coming up from the south. So we originally saw infection in Arkansas, Missouri, and Louisiana, spreading from Texas all the way to Florida, and then coming up north, traveling through Tennessee, Kentucky, and then into southern Illinois, Indiana, and Ohio, and now spreading up to the mid to the northern parts of all of those states. So we have about half the beds and half the both regular nursing floor and ICU beds in Zone 1 in the state. And we're about 75 to 80% occupancy at this point, but it's climbing every day. So this morning we had over 900 patients in the zone. We had nearly 300 in our ICUs. And although our capacity may show 75 or 80%, that was the capacity before we started losing staff. So one of the things that's happened is that we all started losing staff as people started to wither a little bit under the tedium of a year and a half of infection and dealing with these very, very sick patients in the ICU and watching fatalities at a fairly rapid rate compared to our usual number of patients in the hospital. I want to emphasize what Dr. Thomas said in terms of the other patients in the hospital. So we were already full with patients who were severely ill before this recent rise in COVID. And what we think happened is people deferred their care during the pandemic. Maybe they were afraid or reluctant to come to the hospital. Maybe they put off routine checks. And so illnesses, including cardiac disease, neurologic disease, et cetera, cancer, were caught a little later and is driving them to come into the hospital more often. That, coupled with this bulge in COVID patients, is really stressing the system a little bit. In terms of what we're looking at, as best we can tell, we had a peak before in the wintertime of about 5,100 patients in Ohio. We are hoping this peaks out about 3,000, but that's only a guess, as our models are only a guess of what's going to happen. It could be more than that, like Florida, which is actually a little bit more vaccinated than Ohio. We have 5 hospitals actually in Florida with nearly 1,000 beds. They are all under severe strain right now. So we're very attuned to what might happen. We would like everybody to do whatever they can to get vaccinated, but also follow the routine things that we've been talking about before. That's wear a mask, try to keep socially distant, and protect our kids in school by getting vaccinated so we prevent transmission not only from parents to kids, but if kids do become infected, back to parents again so that they're in our hospital. So I'll turn it back to you, Bruce.
Well, thank you again, Dr. Wiley. Well, I think it's clear from what my colleagues have shared that our hospitalizations today are at levels that are quite concerning, and they're increasing at a troubling rate. Now, we need to all do our very best to prevent the spread of COVID-19, in part to allow our hospitals to be in a good position to continue to provide the necessary care that so many Ohioans need. And that includes a variety of other diagnoses beyond COVID, things like stroke or dealing with car accidents, cancer care, and more. Now, given how busy our hospitals are, I want to make sure that people understand that we have quite a bit of COVID-19 testing capabilities beyond what's available through our hospitals. So if your symptoms of COVID-19 are of a mild to moderate nature, and you're really looking to confirm your diagnosis rather than seeking medical advice, testing is available statewide outside our hospitals and emergency rooms. In addition to being able to get a test at many of our pharmacies or other non-hospital providers, we've also partnered with many libraries and local health departments where you can pick up a free rapid test known as Binax Now, which is proctored remotely from the comfort of your home. So you're not having to do that test without some guidance and support. Keep in mind, demand for testing is high, so please call ahead to make sure a test is available wherever you're going to get tested. Now, COVID-19 hospitalizations are also largely occurring among the unvaccinated. And we as Ohioans can really help relieve the pressure on our hospitals, especially over the long term, by choosing to be vaccinated. COVID-19 vaccines remain our very best protection and our best way out of this pandemic. So if you haven't been vaccinated yet, please talk to your doctor or other trusted health professional to get the facts. And now I think we can take questions. Alicia?
Yes, thank you, Dr. Vanderhoff. Our first question today is from Andy Chow with Ohio Public Radio and Television.
Hi, everyone.
Hi.
This question, Dr. Vanderhoff, this is for you. And you just mentioned this, there's a wide availability of these at-home tests now where people can get it, find out if they test positive or not. I was wondering if, when we see these daily case numbers, those are case numbers that are reported into local health departments. Do you think that's an accurate reflection of just how many cases there are in Ohio, given that somebody might just take an at-home test positive, and then just stay home without reporting that case anywhere?
Yeah, actually I do, and it's a wonderful question, Andy. Thank you for asking it. These tests that we now have available that early in the pandemic were a technology and a capability that we simply didn't have the way we do now, are ones that allow us to capture those results very reliably. As I mentioned, these are proctored tests. So in order for the test to be completed, people are working online with a professional who then is able to help us assure that those results get recorded. So more of our continued effort to take advantage of convenience and technology to assure that testing is completed in a timely way and in an accessible way.
Thank you, Dr. Vanderhoff. Our next question comes from Jim Province with The Blade.
Hello. I appreciate your taking our questions again, and this is for you, Dr. Vanderhoff, as well as your colleagues. You've been holding these briefings 1 or 2 times a week, and yet the numbers are still getting worse. Personally, as a doctor, how do you usually react when a patient refuses to take your advice?
Well, that's also a very good question. And I think my colleagues all have had similar experiences in terms of how we help people along the journey of understanding either their illness or understanding the situation that they face. And knowledge really is power. And the way that I've really viewed our efforts has been to help the people of Ohio understand exactly what's happening, to understand the accurate information about the testing and treatment that is available, and especially about the importance of how they can keep themselves and their families safe, particularly through the power of our vaccines. Now, of course, as doctors, we always want our patients to hear the message that we're sharing and take the steps that we think are in their best interests. But we also understand that in order for people to accept our treatment recommendations, we have to be patient. We have to continue to work with them to understand the information and why we are encouraging them in a particular direction. Let me turn to my colleagues. Anything that, maybe I'll start up north with Dr. Wiley, in part because he's also pediatrically trained and might be able to offer some of the perspective that also extends to our younger Ohioans who might be considering vaccination.
Thanks, Dr. Vanderhoff. Glad to take that one on, because when you work within families and you're a pediatrician, you actually have 2 patients. You've got the actual patient sitting in front of you who could be a year or 2 old, or 17 or 18 or 19, and you usually have 1 or 2 parents in addition. I think it involves an honest conversation about what the concerns are with the parents as well as the patient. And there are many concerns out there. There's a lot of misinformation. It can't really just be shrugged off and saying that's inaccurate. You really have to understand, you have to listen, and then you have to explain the relative risks of being vaccinated versus not vaccinated, and what the chances are of getting sick with COVID are, and what it means to be sick with COVID, not only in the acute phase, but also with the 25% or so of patients who develop symptoms that last over the long term that have to be managed. And I think as you explain this and have conversation and take the time, that's when I think you can start to make a difference in terms of the perceptions.
Bruce, I would add to Bob's comment. I use the same approach that I would take if I was doing smoking cessation counseling or talking to someone about weight loss or other lifestyle changes. And the concept is you meet the patient where they're at. I find that most friends, most family members, most patients that I talk to, frankly, are just trying to put the information in context. They hear a lot of information. Actually, one of the benefits, I think, of how the media, most media have covered this, is they're putting out a lot of good, positive, helpful, true, transparent information. It's great that our FDA and our CDC put out that information transparently, but if you don't have it in the proper context, that can be a problem. I had a similar conversation with one of our staff here at the medical center who had not been vaccinated, someone I've known for well over 2 decades, and frankly, she was just scared. Pulled me aside in the hallway and said, will you talk to me for a couple of minutes about this? And she had big concerns about myocarditis with the mRNA vaccine. So it came out a few weeks ago that there is a risk of myocarditis or inflammation of the heart muscle after getting the mRNA vaccine. It's a risk of 1 in 50,000 patients. Tends to be mild, tends to go away on its own, doesn't cause any severe issues. But you have to realize that 1 in 50,000 sounds like it's high risk, but if you realize the virus itself, the risk is closer to 1 in 50 or higher. It's 1,000-fold more risky to let yourself get the virus than it is to get the vaccine. Plus, if you get the vaccine and are protected from getting the virus, to Bob's point, all those other side effects, brain fog, fatigue, missing 2 weeks of work, whatever it might be, don't happen either. So once you put that in context, a lot of people say, oh, well, that makes a lot of sense. there are people out there spreading disinformation that's frankly disrespectful to our communities, that the vaccine magnetizes you, there's a chip in it, all those things. I don't even, frankly, worry too much about trying to convince those folks otherwise. But it's really these people in the middle that have real questions. You meet them where they're at, you treat them with respect, don't be judgmental. And most of them, it's nice. I get a picture the next day or 2 days later with a copy of a vaccine card saying, thanks so much, Andy.
No,
Thank you. And Rick, anything you'd add?
yeah, I'd add, one of the things is that the Latin origin of the word doctor actually means to teach. So that it is about informing your patients. And a couple of things that both Bob and Andy talked about is you need to personalize it. These are raw statistics. How does it affect me? You got to get into understanding the choices, as Andy so eloquently said, and understand the trade-offs, which is not necessarily intuitive. And you really have to discover what are the latent anxieties. And those are the core of any sort of role that a physician plays, is that key role is actually to teach and to understand where they're at, what their latent concerns are, what their choices are, and what that means in terms of trade-offs.
Thank you, Dr. Lofgren. Our next question comes from Titus Wu with the Columbus Dispatch.
Hi. During this press release, a lot of you mentioned about kind of these staffing shortages playing kind of a major role in you guys fearing kind of a new COVID-19 wave. One, I was wondering, I'm not sure if any of you had numbers or anything, but how on average, short-staffed is an Ohio hospital? And two, I was curious if any of the recent, vaccine mandates that, a lot of these hospitals have, recently put in, if that accelerated kind of the loss of staff.
So thank you for that question. I'm going to turn maybe to Dr. Thomas to kick us off.
Sure, I can comment on that. I think that the staffing issues that we're seeing started long before anyone announced any vaccine requirements. We've been hearing about this really since the mid-spring from a lot of our hospitals. It could be early retirements, it could be just people that are frankly burned out, and we've been having them work overtime by their choice, and now they're choosing to not do that. And it's not just nurses either. It's respiratory therapists, it's radiology technicians. It's really across the board. The toll that this has weighed on people with over the last 18 months is kind of uncalculable in a way. I give the folks at the front line in all of our facilities just an immense amount of respect for what they've done and persevered through. So frankly, I believe all hospitals that I know of, at least in my zone, that have put in a vaccine requirement also have exemptions in place for medical issues, religious issues, or certainly many even have for just kind of personally held beliefs. So I'm not aware of at least anyone at my organization yet who has quit their job because of this. It's really more, we don't have the elasticity of extra people and extra hours to expand our beds further as we hear about these numbers of increased hospitalizations. But these trends started long before vaccine requirements have come up over the past few weeks.
I'll just add to that what Andy said is that, even before COVID, we were faced with chronic shortages of healthcare personnel, particularly nursing. The nursing has just risen to the occasion, but people have left the field. I can tell you that early in the greater Cincinnati area, I think there were like 1,600 nursing positions posted before this onslaught of surge and concern about even the vaccines. I think it also what applies to is respiratory therapists. One of the things we've relied on in the past with this chronic shortages says the nurses and others stepping up and taking extra shifts and working overtime and stretching themselves. And I can tell you that workforce is just tired.
Over 20,000 people in Ohio, and considering the mortality and some of the people being younger now, and then we had to restrict visitation to try to keep other caregivers as well as other patients in the hospital safe. So people going through that experience of taking somebody through a terminal event without a lot of family support, and they're the ones providing almost all the support or sometimes all the support in an ICU, is difficult on individuals. And I think everybody did what they could. But as the pandemic stretched out, and particularly in this new wave, so we got to a place where we were pretty excited during the early part of the summer. The rates were pretty low. There weren't many people in the hospital. We took a breather just like everybody else did and thought, maybe we're over this. But Delta hit in the United States in March. It became predominant a few months later, and then it's taken off in the United States. So I think what we're seeing is a reaction to this is coming again. It's very difficult to manage. It takes a lot of interpersonal skills and draws a lot out of people who are on the front lines. So I think that's part of it that we're seeing, in addition to being short-staffed before this pandemic ever started, like the others have said.
Thank you all very much. Our next question is from Anna Huntsman with IdeaStream.
Hi there. Thanks everyone for doing this call. My question is specifically for Dr. Wiley because, we're here in the Cleveland area. So I kind of wanted to, you were talking about there's capacity, but these staffing shortages. It sounds to me like I just want to know more about if you could speak to, are any of the hospitals needing to postpone elective surgeries? Is that something that we could see in the future? Are you lacking equipment? And kind of the second part of this is, do you feel like the northern region will follow suit of what Columbus hospitals are experiencing right now in that regard?
So I'll answer the second part first. So we have plenty of protective equipment. We have plenty of ventilators. Those have accumulated, over the last year and a half. We were short in the beginning, but I think all of us have plenty of that equipment now. In terms of looking at what's going to happen, it's been very difficult to predict throughout this pandemic. So we've seen 4 or 5 surges, depending on how you look at it. I'm not sure we have a good handle on how the virus acts. We see a rapid upswing, a plateau, and then a rapid drop. And we've seen this 4 or 5 times. The biggest and longest surge of about 6 months occurring in the winter time, November, December, January, February, March. The 2 other ones lasting about 90 days apiece. The biggest surge lasting about 180 days. We can't really explain any of it about why it started and why it went away. So we'll have to see what this means. Certainly, as I mentioned, in the southern states, it's already plateaued. It's actually dropping a little bit in the states most affected in the south. So hopefully it'll start to drop here. If it doesn't, I think we have enough staff right now. We also load balance, and I can't tell you how important that is among the hospitals in the zones. So if one hospital is full, we will shift patients to another hospital. We'll transfer people up from Columbiana County up to the Akron area, and from Akron to Cleveland, from Toledo to Cleveland, from Youngstown to Cleveland or Akron, just depending on where we need to load balance so that no individual hospital gets overwhelmed. And then in between zones, and Andy and I did this in the last couple days, was we started saying, can you take it? Can we take it? What's the best place for these patients to be hospitalized for the intensive therapy they sometimes need? So we talk frequently in terms of load balancing, and that's a big part of what we've done within the zone. So I think we're okay. We're going to keep our fingers crossed that we don't end up like some of the states in the South. I think if we got to the place, and right now nobody's deferring any cases in Zone 1.
So this is Bruce Vanderhoff. One of the things I would add is to just highlight how advantaged Ohio is by the dialogue that occurs on a routine basis between hospitals all across the state, as well as the coordination and infrastructure that is built into our regional and zone structures. They really do allow us on a day-to-day basis to have our hospitals working collaboratively for the good of our patients and the good of the people of the state to assure that our beds are being utilized in the most effective and efficient way. And it's a real asset that Ohio has that many other states lack.
Thank you very much, Dr. Vanderhoff and Dr. Wiley. Our next question is from Laura Hancock with Cleveland.com.
I was wondering, we're seeing reports out of Texas where they're having to train to nearby states because the and I'm wondering, in particular, in Southern Ohio, are we from maybe like Kentucky or, other places, Indiana, are saying, we're overwhelmed. We need Ohio to help us. And at what point does Ohio take some capacity for our own people?
Yeah, you were cutting in and out, so I think I understood the question, and I'll answer accordingly. But so when we're looking at the issue of how do we effectively within the state manage this kind of wave of COVID hospitalizations, a lot of how we do that very effectively is what I described just a few minutes ago. We have a very robust regional and zone-based structure that allows for hospital leaders across the state to be in regular dialogue with one another and to be thinking about the needs of our patients and assuring that that patient care occurs. It's actually one of the most robust structures of its kind in the nation. So that's something that happens behind the scenes that I think we can all be very, very proud of. And these three doctors play a very, very important role within their zones of the state in helping to assure that that infrastructure functions in a very effective manner. As far as the relationship with other states is concerned, we are in regular dialogue with at least I'm involved in regular dialogue with the health leaders of the other states. And we have been talking about their needs and their challenges. The challenges, for the most part, that I've heard really relate to this staffing challenge as opposed to physical beds or equipment needs. And they are significant and challenging issues. And there have been, I know, times where patients have been admitted across the lines of our states, and our hospitals have been historically, even before COVID, very good about receiving patients from other states who are in need of care. But in terms of some of the specifics around that, I'll defer to these three physicians who are much more aware of the day-to-day events related to that kind of transfer.
Yeah, Bruce, I'll start. It was 2 weeks ago today when I got my first call from an emergency management person in Texas. The four of us on this call all spoke that day, and pretty much they wanted to fly individual patients here in fixed-wing airplanes because they were out of beds and had used up all of the capacity in their adjoining states, Louisiana, Oklahoma, et cetera. And unfortunately, we knew this train was coming down the tracks and made the decision to not engage in that discussion to transfer patients from Texas here. I think others on the call have gotten calls from other states as well. I can tell you at Ohio State, starting about a little over a week ago, we've stopped taking transfers from out of state unless the patient is an Ohio resident or an established patient of the medical center here at our James Cancer Hospital, or a transplant patient, et cetera. If they're an Ohio resident, we'll take them from anywhere. But unfortunately, we get a lot of referrals from hospitals in West Virginia and Kentucky. And we've had to ask those doctors to call the hospitals in their state, because we feel we have a commitment to those hospitals, those providers, and certainly most of all those patients in those communities in our zone that are going to need that hospital capacity that's in short supply here in Central Ohio. So it's a very, very difficult decision to make, but one that we feel we had to make at this time.
I might add is, and your question was actually in Southern Ohio in particular. I'm going to echo what Dr. Vanderhoff said, is that the fact that the state took the initiative to divide it into the three zones and make sure that there's ongoing collaboration between the facilities has been outstanding, and really even the collaboration across the entire healthcare system, including congregate living and nursing homes and public health. And it is unique, and I think it has served us extremely well so that we actually can optimize the resources and provide the best care to Ohioans. Being in Southwest Ohio, of course, we also do collaboration with the tri-state, meaning in our immediate area of Kentucky and Indiana, and make sure that we're working as a region as well as through the state. But just this anecdotally to follow up what Andy said, really you do hear what's happening in the southern states of Louisiana, Alabama, Texas, who are truly just overwhelmed. We're extremely busy, but we just recently got a phone call from a request to transfer a patient from Alabama with requiring emergency surgery on their aorta because they couldn't find anybody from there to actually take the patient. And frankly, we are at capacity that we weren't able to accommodate it. So, these are the things that we're trying to avoid.
So it's a reason to get vaccinated again, is to try to reduce this load and this burden we're talking about. In terms of the Cleveland Clinic, we sent doctors and nurses to New York and to Detroit when they were overwhelmed early on in the pandemic. We are very cognizant of the needs of the patients we care for in Ohio. We certainly, if we can provide service that nobody else can or typically provide, like somebody who's had COVID and needs a lung transplant and they've recovered from their COVID, because we're the highest volume transplant center in the United States, we'll try to make special accommodations for those. But we're all trying to manage in terms of what we're doing now. So we'll do what we can. We try to help out. We give consultation. We do telemedicine visits with people in terms of trying to help them in their ICUs. And we'll help whatever way we can. But we're all Ohio based, and certainly cooperation. And we know we have to load balance within the state so that we can treat everybody who needs to be treated within the state of Ohio.
Thank you, doctors. Our next question comes from Jess Harden with Mahoning Madison.
Hi, thanks for taking our questions today. My question is for Dr. Vanderhoff or anyone who wants to weigh in on this. Senate Bill 22 limits Governor DeWine from reissuing a health order until 60 days after the previous one was terminated or expired. And he terminated Ohio's state of emergency on June 18th. 60 days after that is August 17th. And given this Delta surge that is approaching the crisis seen this winter, the worst of the emergency so far, would you recommend such an order to Governor DeWine?
Well, I think that my role is to provide good medical guidance and medical advice, to share information, not just with the governor, but with the legislature. And we work very hard to do that. The bottom line for all of us as Ohioans, though, is that regardless of whether there's an order or no order, the steps that we need to take to beat this pandemic are very clear, and ones that ultimately rest with us. There are ultimately decisions that require us to take a personal action and accept personal stake in what's happening. You've heard us talk now repeatedly in today's press conference, as I have in other press conferences, about the importance of vaccination. Vaccination is clearly making a difference. If we just reflect on the fact that I shared, that nearly all of our hospitalizations are occurring among the unvaccinated, it really provides a very clear illustration of the truth of what we as physicians have been speaking to in terms of the importance of every Ohioan considering getting a vaccine. And for those who can't be vaccinated, or when we are entering into environments where the risk of spread of the virus may be very high, layering on those other protective measures that served us well in our previous surges, masking, distancing, being mindful of hand hygiene and ventilation, all become very important and are personal decisions and responsibilities. So, at the end of the day, I think that we can get a little distracted by wondering about, a piece of legislation or a particular governmental action from what is really most fundamental. And that is that each of us as Ohioans has to think about our role in addressing this pandemic and take the steps that are available to us to keep our friends, our families, ourselves, our coworkers safe, and to get this thing behind us.
I understand that the message remains the same regardless of whether or not there is an order, but that doesn't appear to be working.
Well, actually, I think that we're making real progress. If you look across the world, the Delta variant has had a huge impact on various different countries. And the one differentiator that really seems to separate those communities at greatest risk from those communities at lesser risk is rate of vaccination. And as I shared before, we're making progress on vaccines. Now, would I like to see higher vaccination levels? Of course. And we're going to continue to work as medical professionals and as the state of Ohio to help get those vaccine rates higher and higher. But clearly, what makes the most difference to a population, whether it is a country or a state or a county, is what the vaccination level is. And places with high vaccine levels do much better than places that have low vaccine levels. So that really needs to be our focus.
Thank you, Dr. Vanderhoff. Our final question today comes from Pete Grieve with Spectrum News.
Hello, good afternoon. I was hoping to ask about monoclonal antibody treatments because we're seeing reports in the South that there's growing demand. Curious if that's the case in Ohio as well. And then also if you could just share which drugs specifically or drugs are being used.
I can certainly begin that and say that yes, monoclonal antibody therapy does remain an important component of the treatment that is available for patients diagnosed with COVID-19, and our physicians and hospitals here in the state are in fact utilizing it to an increasing degree. We have very good supplies of the monoclonal antibodies available here in Ohio and are constantly monitoring to ensure that that supply remains adequate to serve the needs of the patients. I'll turn to my colleagues who are at some of the medical centers that are actually providing these treatments to speak a little bit more to the current available therapies. Maybe I'll start up north with Dr. Wiley, and then we can kind of move through Drs. Thomas's and Lofgren. Dr. Wiley?
Certainly, we're using more monoclonal antibodies than we have in the past. Not only after patients start to get sick before they have much oxygen requirement, but also as a preventive measure for those who are more likely to get sick if they've been exposed. And we see more and more physicians becoming aware of the therapies, and we've actually increased the number of days of infusion. And we do it at Marymount Hospital as a central place within the Cleveland Clinic, as the other hospital systems are also using it throughout Zone 1. I know Andy has had a lot of experience with it.
Thanks, Bob. We use at Ohio State, we use the Regeneron product. That was one of your questions. We were actually part of the clinical trials for the Eli Lilly product initially as well. So we've been involved even when it was in the study phase. We reopened our infusion center 2 weeks ago. We did more in the first 2 weeks of August than we had done in the previous 4 months because the numbers had gotten so low of individuals that needed the infusion. So it's been a great effort. We're now infusing 7 days a week. We infuse at a center at OSU East Hospital in our ambulatory care center. It's a great collaborative effort between our physicians, our pharmacists, our nursing staff. The one thing I will say that's new over this past 2 weeks is providers, physicians will identify their patients who are at high risk. We have a consult process that goes through one of our pulmonologists, and the pharmacists get on the phone and call the patient. We're now seeing some unvaccinated patients turning down the monoclonal antibody treatment because they basically are saying, I didn't want to get vaccinated. I don't want any of this either. And when you think about short-sighted decisions, this is a medication that if you're high risk for admission to the hospital for severe disease from COVID, it can reduce your risk of admission by 70%. And people are turning down that treatment because I don't really understand why. Anything that we can do to make sure people understand, if your doctor tells you that this is beneficial for you to keep you out of the hospital, it is worthwhile doing. It's a simple single infusion. takes an hour or less. To Bob's point, we are working with some local nursing facilities on post-exposure prophylaxis. We don't have the capacity to do that internally in our medical center right now, but we're working with some local nursing facilities to stand up protocols. We're also working with the Ohio Department of Rehabilitation and Corrections, both for monoclonal infusions for positive patients as well as for post-exposure prophylaxis. Rick?
Yeah, I would just echo what both Doctors Wiley and Thomas said, and that we have seen a real uptick in the use of a monoclonal antibody. But I think the real concern actually along there is we're not using it enough. And getting back to the story that Andy said is that, given the upsurge that we really are encouraging people that come who are eligible, who would really make a difference, that they really do get it. So we're spending some time and effort trying to make sure that we're reaching physicians and practitioners to really people understand this 70% reduction is very effective therapy. Bruce, the one thing I did want to come back to, you talking about with the surge and what can we as a community do. Obviously, what we can do to get this pandemic behind us is really get our vaccination rates up. But I would want to make sure we echo the fact that here and now, with the surge in place, what anybody can do is actually take those simple measures we know that work. And that's returning to wearing a mask indoors. It actually applies if you're vaccinated or not vaccinated, since we've seen some breakthrough infections in vaccinated. They do better, but they still are concerned about the risk. And so I do want to say, vaccines are the way to go. That will make a huge difference. There is a delay in time. This is a here and now problem. Our emergency rooms are crowded. We're pushing the envelope. And really one of the things that is very simple is to return back to those things that we know that work. Stay, the social distancing, wearing a simple mask in indoor events really can make a big difference in helping our workforce today.
Yeah, Bruce, if I could add to Rick's comment about face masking, I think when you look at the rural areas of Zone 2, which are regions 7 and 8, we talked about 1 in 10 patients in the hospital for any reason have COVID, 1 in 6 in the ICU. In the rural areas of Zone 2, 1 out of every 3 patients in an ICU in those areas have COVID, and 1 out of every 2 patients on the ventilator have COVID. So I think specifically, those are areas that at different times have been very much spared from the pandemic. That's not the case now. We're seeing the same upward trends in COVID cases, COVID hospitalizations, ICU stays in the rural parts of our zone. And I think when we think about K through 12 schools going back and the gasoline that could add to the fire of this increase in cases, I think getting more schools to understand we already saw our first school district close for a couple of weeks down in Southern Ohio this week because of the increase in cases just a week or 2 into school starting. So I think that for parents out there, I'm not the pediatrician here, Bob can comment, but for parents out there, I know I send my 13-year-old to school every day, and luckily his school has adopted full masking K through 12. But I think that's the only safe way to keep your child safe in this environment with the Delta variant.
Thank you, doctors. That was our final question for the day. Dr. Vanderhoff, I'll turn it over to you if you have any closing remarks you'd like to share.
Thank you, Alicia. I just want to close by again thanking my 3 colleagues for taking time out of their schedules to help us share this message, and to all of you from the media for taking your time to hear these important messages and to help us share them more broadly across the state. Thank you.
Thank you for joining us. If you need access to record or would like to ask a question, please indicate so in the chat. We will limit questions to one question per outlet on the subject matter today. In addition, we are limited to 1 hour, and I apologize, Dr. Forbes will be leaving at approximately 12:30, so he will have limited access, or noon, he will have limited availability for questions. So if there are any remaining questions in the queue when we conclude our hour, please send them in the chat or via email, and we will work to get you a response in writing. All right, Dr. Vanderhoff, I believe we have everyone in the room. I will turn it over to you. Thank you, sir.
Well, thank you very much, and good morning. I'm Dr. Bruce Vanderhoff, Director of the Ohio Department of Health, and I appreciate you joining me today. For some time, I have said I believe it is a matter of when, not if, the Pfizer vaccine receives full FDA approval. Now that day has come. Full approval of this safe, effective COVID-19 vaccine can give Ohioans an added layer of confidence when choosing to be vaccinated. The Pfizer COVID-19 vaccine was built upon decades of mRNA vaccine research and was thoroughly evaluated and tested in one of the largest vaccine clinical trials in history. The world's most comprehensive vaccine safety monitoring system has closely observed the more than 200 million doses that have been administered in the United States, including more than 6 million doses administered right here in Ohio. This action by the FDA validates the confidence of so many physicians, scientists, and public health experts in the safety and efficacy of the Pfizer COVID-19 vaccine. For any Ohioan who has been waiting to receive the vaccine until full approval is granted, today is the day. Pfizer vaccines are readily available at providers across the state, and COVID-19 vaccines are our best protection against the virus. Although the FDA approval is good news, our Delta wave of COVID-19 continues to drive our numbers ever higher. Our cases per 100,000 averaged over a 2-week period, which just a month ago were less than 50, are rapidly approaching 300. Not surprisingly, in just a month, our adult hospitals have seen their COVID hospitalizations jump almost 5 times higher, creating real stress and challenging their ability to maintain some services. Sadly, in addition, more Ohio children are now landing in the hospital due to an unexpected summer surge of respiratory illnesses. And with COVID-19 on the rise, we may be approaching a perilous situation. At this time, the Ohio Children's Hospital Association has reported that they are seeing a wave of respiratory viruses and illnesses typically seen in winter rather than summer, namely rhinovirus, parainfluenza virus, and respiratory syncytial virus, better known as RSV, all on top of COVID-19. Rhinoviruses are the leading cause of the common cold, and they can trigger asthma attacks and have been linked to sinus and ear infections. Parainfluenza virus, not to be confused with the flu, causes upper and lower respiratory illnesses, particularly in infants and young children, older adults, and people with weakened immune systems. It can also cause croup, bronchitis, bronchiolitis, and pneumonia. Finally, there's RSV. In older children and adults, RSV mostly causes mild cold-like symptoms. But in very young children with smaller airways, such as toddlers and babies, RSV can be far more serious, causing trouble breathing, pneumonia, and bronchiolitis. RSV infections typically occur in late fall, winter, and early spring. This unseasonably early increase in RSV, coupled with rising pediatric cases of COVID-19, is a recipe for disaster. Although, thankfully, our children's hospitals are not yet at critical capacity levels, we're very concerned. Emergency departments, ICUs, and hospitalization rates are at levels more comparable to what we experience in the winter. It's not winter, it's August, summer, and therefore, it's likely that the worst is ahead of us. On top of this wave of winter pediatric respiratory viruses, based on the pattern seen elsewhere, we can expect further increases in COVID-19 case rates driven by the highly contagious, dangerous Delta variant. And it's not really an issue of children being at risk for COVID or one of these respiratory illnesses. In fact, it's not uncommon for children to come down with 2 respiratory illnesses at once. Nationally, there have already been reports of children simultaneously developing RSV and COVID-19. And while not enough is yet known about the impact of having both viruses together and whether having COVID could worsen the course of RSV, I firmly believe that most parents of young children don't want to find that out and would prefer to take preventive measures to protect their children. So as we're sending children back to the classroom and into extracurricular activities, we have to be cognizant of how we can keep our children safe and healthy. The very best way to prevent COVID-19 is vaccination. Vaccination is simply the best way to protect eligible youth from getting COVID-19. And for younger children not currently eligible for the vaccine, the adults and teens around them can substantially insulate them by choosing to be vaccinated. Thankfully, we continue to see eligible Ohioans choosing vaccination, and we're coming very close to 60% of those 12 and older having started their vaccines. Another way to protect children, of course, is with masks. Last year, we saw remarkably low numbers of other respiratory illnesses, including RSV and influenza. And as you'll recall, we were all wearing masks. As we've discussed before, mask wearing significantly reduces the risk of spreading respiratory viruses from one person to the next. When you're infected with COVID-19, many times unknowingly, you can pass the virus to someone else simply by talking. That's because COVID-19 spreads from person to person by way of respiratory droplets released when an infected person sneezes, coughs, or talks. When worn properly, the mask blocks your respiratory droplets from reaching another person. And it isn't just COVID-19. Other respiratory illnesses are spread by droplets as well. We saw the impact of masking this last year when masks helped limit the spread of COVID-19, along with other respiratory illnesses. There were simply far fewer cases of respiratory viruses like flu, RSV, and colds. But when the masks came off, people started getting sick again. Now, as we see these abnormally high numbers of summer RSV cases among children, just as we're encountering a tremendous Delta wave of COVID-19, we continue to urge caution. But there are steps we can all take today. First, choose to be vaccinated from COVID-19. This flu season, get your flu shot. Wear a mask. Wash your hands. Practice social distancing. Do it to protect yourselves, to protect the children around you, and to protect the babies too young to protect themselves, who are vulnerable to severe cases of RSV. Now, joining me today are two highly respected pediatric experts to talk about what we're currently seeing in Ohio's children's hospitals and about what we can do to protect Ohio's children. First, I'm joined again by Dr. Michael Forbes, a pediatric intensive care specialist at Akron Children's Hospital and interim chair of the hospital's Department of Pediatrics. So first, let me turn to a question, Dr. Forbes, about RSV. Can you tell us a little more about the virus and who is most at risk?
Sure. Thanks again for having me. RSV stands for Respiratory Syncytial Virus. That middle word there, syncytial, is a mouthful, but really speaks to the unique way that RSV injures the lung. And so we know that RSV is a common, highly contagious seasonal virus, as you mentioned earlier, that typically shows up with, what I consider the gang of viruses every winter: flu, paraflu, rhino, RSV. They're all together in the flu season, or in the flu and cold season. In March of this year, the CDC issued an advisory that we should all be on the lookout for what they saw as an uptick in RSV. And the rationale behind that really was they were seeing it nationally. And we know that this year's RSV or last year's RSV tends to give you some degree of background immunity to this year's RSV. And as you alluded to earlier, we didn't have much RSV last year, or flu. And I really want to point out the fact that we have a flu vaccine, and we had very, very little flu. We don't think the reduction in flu is just a vaccine. There's no RSV vaccine, and we almost eliminated RSV in many hospitals last year. And so it wasn't the vaccine, it was the masking. And so it's really important, and I think it's kind of a, not a study, but I think a really important observation that we virtually eliminated RSV just by masking and distancing and keeping our hands clean last year. So really important. You ask who is also at risk. Every child, pretty much every child's infected by the age of 2. So we've all had RSV, but there's a specific group in particular, high-risk group. Babies born preterm and babies born with certain heart and lung conditions are also uniquely vulnerable to severe RSV disease.
Well, thank you, Dr. Forbes. You mentioned that RSV is particularly dangerous for those young children. What are the concerns for families who may have young children in daycare centers or schools, particularly for those who may have those less than 2 years of age? What safeguards would you suggest they consider?
Sure. For infants and toddlers, if you have siblings who are in daycare, if those kids are in daycare, or if they're siblings who are in school, it's important to make sure that you continue to do what you've been doing throughout this pandemic. That is, wash your hands, physically distance, and wear a mask. You can also talk to your healthcare provider to find out if your child at home is at high risk. Again, preterm babies, kids with certain heart and lung conditions, to find out what you can do from a preventative standpoint to protect those children. In the meantime, again, continuing to use the toolkit, right, the pandemic toolkit, as far as distancing, hand washing, wearing that mask, and really choosing to wear that mask whenever possible to make sure that we're not continuing to spread RSV and any of the other viruses.
Dr. Forbes, as I reflect on my clinical career, I simply can't remember a summer with RSV levels anywhere near what we're seeing now. Can you tell us a little bit more about why you think we're encountering this wave of RSV now in what is really the hottest part of summer?
Yeah, great question. I don't think we really know, but I think we can speculate. We know that from year to year, last RSV season does create some degree of background immunity for the next season. We also know, as I mentioned earlier, that the masking and all of the toolkit actions that we took really works. And so what we have this year are a group of children who have no background immunity. And when I refer to background immunity, among children and among adults, because RSV affects adults as well. And so you have a group of a vulnerable population. And I think what we saw here is also what was reported in Australia is once we lifted our restraints and people began to interact again, not only and folks were vaccinated against COVID. And so we didn't see certainly a spike in COVID right away, but we saw what was in the background, and that is RSV. And so now we have the RSV spike in the middle of the summer, which is unusual. We're usually less than 1% positivity at this time of year. We've been as high as 40% in Akron and around the state. So it's very, very unusual, but we are dealing with it. And honestly, the good news is we're smarter than ever around this. And I think we've learned that masks really, really work. I mean, it was controversial earlier in the pandemic. I think the controversy is over. Masks are highly effective, and as well as the rest of the toolkit, of course.
Thank you, Dr. Forbes. Next, I'm going to turn to Dr. Manning Courtney. Dr. Manning is the Chief of Staff at Cincinnati Children's Hospital Medical Center. Dr. Manning, I know that pediatric experts like yourself have been closely following the information that we're seeing coming out of other areas of the world and out of our southern states. What are you hearing regarding Delta and COVID-19, and what could that mean for us right here in Ohio?
Sure. Thanks, Dr. Vanderhoff, and hello, everyone. I think you've all heard this. We've been paying very close attention to our southern neighbors and seeing the rising numbers of children with COVID. Not just more children with COVID, but children who are getting sicker with COVID. And we don't really have to look much further than Tennessee. We certainly look at Alabama, Florida, Tennessee, and even Kentucky. We're seeing those numbers increase. Last week on a phone call with our Ohio Children's Hospital Association partners where we share information, it was clear that the movement of positive COVID children seemed to be going south to north. And so here in Cincinnati, we were feeling even more, higher numbers of children that were impacted compared to some of our neighbors to the north within the state. And so we're concerned. We're paying very close attention, and we're experiencing that here in Cincinnati.
Well, of course, these respiratory viruses are all happening together at the same time, COVID with RSV and some of these others. And of course, that has an impact on our pediatric emergency rooms and our pediatric intensive care units. If we continue to see this kind of upward trend in COVID-19, along with these other respiratory illnesses, what impact could that have on our pediatric hospitals statewide?
Well, the biggest impact that it would have is that we would be dealing with a higher volume of sick children. And that higher volume affects everything that we do. It affects the flow of our patients through our system. So first, patients might back up in the emergency room. And we hate when that happens. We can't stand when somebody is waiting hours and hours for a bed, or they're in a room for a long period of time waiting to be cared for. The next thing that can happen is that our hospital beds themselves become full. And that affects other patients that we can take into our system. Particularly within our intensive care units. When our intensive care units become full, we get very concerned about how we will handle our sickest patients, how we will receive transfers from other areas, or how we will even handle things that we call elective surgeries or elective procedures, but they're not really elective. These are children who need surgeries for cancer, for tumors, for fractures, or for other critical conditions, but they're not urgent. And so we worry that we have to delay care because the volume of children that need us is so great that we have to make some hard decisions about what we can and cannot do. And we just don't want to be there. We want to care for everybody and give them the care that they need.
Thank you. You know, we know people are tired of dealing with COVID-19. I think people were hoping that we were finally done with having to deal with the masks and that we could get life back to what we remember before COVID-19. But now with the highly contagious Delta variant, it's really not the time for us to put those safety measures behind us, particularly for our young children who can't get the COVID-19 vaccines. With the spread of RSV and in the face of this COVID Delta wave, what recommendations would you offer as a pediatrician to families of Ohio?
You know, to Ohio families, I would say, as you've already said and Dr. Forbes shared, if you can get vaccinated, please get vaccinated. A vaccine is like a shield. I've been thinking about a vaccine like a shield. And the more of us that have shields, the safer we all are. No shield is 100%. And so in addition to getting vaccinated, wearing a mask when you're indoors, including in schools, using hand hygiene, and really thinking twice about those gatherings that seem to place us at risk because we don't know everybody's vaccination or disease status. But really the way I've been thinking about it is this. You know, we are charged with caring for the sickest children in Ohio, children with cancer, children with organ transplants, children with genetic disorders, children with all kinds of conditions that we're uniquely positioned to care for. And we can usually do that without any help. We don't ask you for help. We're asking for your help. We need your help so that we can continue to do the things that we're uniquely able to do. And that help comes in the form of getting vaccinated, wearing masks indoors, including in schools, using hand hygiene and social distancing.
Thank you so much, Dr. Manning. Ohio's Delta-driven wave of COVID-19 continues to drive cases and hospitalizations ever higher. And with Ohio's children's hospitals already seeing high levels of respiratory illness in line with what they would normally see in the winter, plus increasing cases of pediatric COVID-19, we must all do what we can to protect Ohio's children. Now, vaccines remain our best protection against COVID-19. And today, with the announcement by the FDA of their full approval of our COVID-19 vaccine from Pfizer, I think those who had been waiting for that extra sign of approval can really rest assured and can get in line for the vaccine. But for children who are not able yet to receive the vaccine, the layered prevention measures we have become so familiar with, masking, washing our hands, maximizing distance between ourselves and others, ensuring good ventilation, these remain vital to help keep us safe as we continue to battle against COVID-19. And now, Alicia, I think we can take questions.
Thank you, Dr. Vanderhoff. Our first question comes from Danny Eldridge with Hannah News.
Hello, Director and doctors. Thanks for taking your time today. So my question is about staffing at these hospitals. I'm hearing that there's been issues with having enough staffing. People are being offered a lot more overtime, and also the fact that hospitals could have enough beds, but if you don't have the staff to take care of people, I mean, that's obviously a huge issue. So can you just talk a little bit about that and what the hospitals are doing and what the state's doing to try to address that issue?
Well, I think for that, I'll turn to my two colleagues. Dr. Forbes, I know your time is limited. Maybe you could start and then we'll turn to Dr. Manning.
Sure. Thank you very much. And I appreciate the question. I think that it's nice to hear that the folks out there recognize the hard work that's been going on for over a year now, year and a half within all of our hospitals. I read a statistic recently that over 500,000 people left the healthcare sector altogether last year. And that really is, it's telling. At a time when we need more people, we actually have less people. And so our organization is committed at the executive leadership level. I know most of the hospitals are thinking along the same lines. We have to take care of our people because our people take care of our patients. And so we don't want care delay that Dr. Manning alluded to, care delay and care failure and even patient harm. We take care of children who can't even climb a flight of stairs, and they're old enough to do that. And that's because of their condition, their state, and that's what we do. And so we know that, and we're dedicated to those kids and keeping our promises to those children and their families. And so we are looking at every opportunity to recruit as fiercely as we can. We are very committed to retaining every single member of our staff. We can't lose another nurse, respiratory therapist, medical assistant. This is all hands on deck for us. And you alluded to at the top of our meeting today that it likely will get worse. We want folks to join our groups, join our hospitals, and help us in the fight to stay on top of this. And in addition to the recruiting and retention efforts, I want to put another plug out there. Please choose to get vaccinated if you're eligible. Please choose to wear your mask. Both of those are so effective, so that if we don't get more people, we can at least take care of the children who come before us for help. So thanks again for the opportunity.
Dr. Manning?
Well, the only thing I could possibly add to everything that Dr. Forbes said would be that it's so dramatically different from last year. I've said this a number of times. Last year, we had, everybody was wearing a mask, and so we had far fewer sick children, and we had better staffing. And as you heard Dr. Forbes share, we're all experiencing a pretty significant exodus of people from healthcare for all kinds of reasons. It's been a hard year and a half. And some people have just said, you know, this is, I can't do this anymore. So we're all recruiting aggressively. We're adjusting pay and referral sources and doing everything we can to hang on to those very critical frontline providers, nurses, MAs, respiratory therapists. Every person plays such a critical role in the care of children. And the part that you can do, the way you can help us, as I already said, is to get your vaccine, wear your mask, wear masks in schools, do everything you can to keep the children in your lives from getting sick, because that helps mitigate the staffing challenges that we all have.
Thank you, doctors. Our next question comes from Josh Rultenberg with Spectrum News.
Hi, Dr. Vanderhoff. I just wanted you to clarify something before I ask a question. Earlier in the press conference, I believe you said the case number per 100,000 over a 2-week period. Did you say that it was approaching 300 or it's at 300?
Yeah, approaching. So we're seeing those numbers rise. It's really been quite dramatic. As you know, we went back to the beginning of July. We were as low as a little bit north of 17. Now, as you look at our numbers, we're between 250, 300, and I fully anticipate we'll go north of 300 cases per 100,000. And remember, the thresholds that have traditionally been used have 100 cases per 100,000 as an indicator of a very high rate of spread of the virus. So to be at 300 or to be at 250 or 200 means you've got a lot of spread all across the state. And we have not seen numbers like this since our last winter. So these numbers look like what we were seeing in February.
So with that said, when Governor Mike DeWine removed the mask mandates, originally he had said he wanted that below 50 per 100,000. He, of course, did it before, but then when June 2nd came around, it was close to that. So my question to you is, should Governor Mike DeWine reissue a mask mandate or even have a vaccine requirement and let the state legislature consider keeping it in place afterwards? And why should kids go back to school in person if these mandates are not made, considering how dangerous things are getting?
Yeah, so a number of things there are a number of questions there. So first of all, let's remember that the most effective thing that we can do for those of us who are eligible to be vaccinated is to receive a vaccine. And from the beginning, we've made it clear at the state level that we see vaccination as being something that's an important choice for the people of Ohio to make. But you know, the good news is we are actually seeing and have seen now for a couple of weeks, more and more Ohioans going in and getting the vaccine. That's why I pointed to that very, very hopeful statistic that it appears to me that we're on the cusp of being able to cross the 60% threshold for people 12 plus actually having begun the vaccination process. So I do think that Ohioans are hearing this message and are taking up the challenge to receive vaccines. Today's announcement by the FDA of full approval for the Pfizer COVID-19 vaccine, I think is just one more reassurance for people who may have been somewhat on the fence about whether this was the right time for them to receive vaccination. So I'm really encouraged by the progress that we're beginning to see there. You know, in terms of the safety measures that we can undertake as our children return to school, we already know from experience here in the state that we can safely return to the school year. And we can do that by using the layered safety approaches plus now vaccination to assure that our students have a good year and without disruption to their academics or their extracurriculars. But that only happens when people take advantage of both the opportunity, if they're eligible, to get vaccinated and wear masks and practice appropriate distancing, hand hygiene, etc. So there is no reason for our students not to be returning to school. There's every reason for us to resume in-person education. And at the end of the day, no mandate is going to be able to have an impact without the people of Ohio being behind the measures. And education about what's happening, education about what people can do remains probably our most effective way of helping to help the people of Ohio get ahead of this wave.
Thank you, Dr. Vanderhoff. Our next question is from Allison Walker with WKEF in Dayton.
Hello, everyone. Thanks so much for taking the time today. Dr. Vanderhoff, does FDA approval of Pfizer mean that it's likely that Pfizer will be approved for children under 12 years old sooner than expected?
Well, I can tell you, and I shared this in my opening comments, and I've said it before, I think it has come as no surprise to the medical community that the Pfizer vaccine received full FDA approval. When we look at the sheer volume of case information that we have, the sheer volume of the safety record that we have for this vaccine as well as our other vaccines, it's clear that the vaccines which we have access to have been thoroughly and very completely studied, that they are safe, that they are effective, and that we understand very well what their limited side effect profile is. So I fully anticipate that the younger age bracket will follow behind the 16 up age bracket in receiving full approval from the FDA. But I think that it's to the FDA's credit that they continue to move through a thoughtful, deliberate, and careful process of completing all the steps that they've committed to in their approval process. So yes, I am very confident. I know, Dr. Manning-Courtney, you've been involved with a team that has played an important role in some of the research around the vaccine. Would you want to add to that?
Sure, I would simply add that we've been so fortunate that here in Ohio, we've been involved in these trials here at Cincinnati Children's. We've had local children participate in these trials, and we are very optimistic that an approval for children between 5 and 12 will be coming in the very near future.
Thank you. Our next question is from Joe Ingles with Ohio Public Radio and Television.
Hello, Dr. Vanderhoff and the other doctors. My question is, we've got these kids going back to school, and we know that many of them, the younger ones, cannot be vaccinated. And a lot of these kids, if they are around someone who has COVID, they may be taking these at-home antigen COVID tests, which it's up to the parent, it's up to the person administering that test to be honest and to submit those results. There is some anecdotal evidence that maybe kids are being sent to school with positive COVID tests, not taking long enough to quarantine or isolate. What can you say about, what advice can you give people about how to handle that situation?
Well, of course, thank you for that very good question. The reason that a person should be tested is both to identify whether or not they are infected with COVID-19 and to ensure that they are not inadvertently posing a risk to other people. While, of course, there's always a risk that some individuals will not take the situation seriously, I just don't think that's true for the vast majority of people in the state of Ohio. With all of these issues, whether it is an issue of being tested, whether it is an issue of receiving vaccine, of wearing a mask, there is a level of personal responsibility that all of us have to the community, to the people we care about. And what I would ask people to remember is that this is about, yes, your health and your family's health, but it's also about the health and safety of people you care about, your friends, your neighbors, your coworkers, your other family members who live outside of your home, including some family members who may be of advanced age or have other medical conditions that place them at greater risk related to COVID-19. So at the end of the day, we all have to work together to overcome this COVID-19 Delta wave. And that's the only way that we'll be successful.
Thank you, Dr. Vanderhoff. Our next question is from John London with WLWT News 5.
Thanks for all you've said so far. I wanted to ask Dr. Manning, and maybe Dr. Vanderhoff might weigh in as well. You all emphasize vaccination, which you have been doing consistently throughout the pandemic. The reality that I see, and correct me if I'm wrong, but of the 12 to 17 age group, the percentage that have been vaccinated so far is relatively low, I guess you would say, somewhere in the neighborhood of 30%, I believe. We got schools back. And so two things, with the RSV being what you say it is, Dr. Manning, what's the outlook here for the next few months? And then for both of you, why isn't, I know you mentioned social distancing, but it seems like it's one of the safest things. Do you think it's being emphasized enough? Because ever since the health orders were lifted, that 6-foot space, from my observation, has really shrunk out in society.
So I'll take that.
Yeah, you start, Dr. Manning.
I'll start. So you are correct. The vaccination rates in the 12 to 17-year-olds could be better. They're in that 35% range. And we are doing lots of things on our campus to make it easier for children in that age range to get vaccinated, whether it's through our clinics, through our primary care clinics, and our community physicians are doing an amazing job offering vaccination to their patient populations. I think there is still some hesitancy amongst families in that age range, but as you recognize, it's critical because I'm not even thinking out a few months. I'm thinking out a few weeks right now, frankly, with RSV and with COVID. And at the rate that things are rising with kids, between RSV and COVID, we have to do everything in our power right now to get through the next few weeks. And then I can worry about the next few months. And that means getting vaccinated, wearing a mask in school, and to your second point, being better and more vigilant about social distancing. I do think we've learned that social distances can probably be in that 3 to 6 foot range, but we're certainly seeing lots of gatherings and lots of activities where people are in quite close contact without masks. And this is really the time to revisit those types of activities. Ask yourself, do we have to go to that party? Do we have to go to that event? If we do, should we wear a mask? Because there's, just like a year ago, we talked about these types of events where COVID could spread very quickly. Delta does that 3 times more effectively than the variants that we were dealing with last year.
Yes, thank you. And I think what I would add to Dr. Manning's comments is that I think for too many Ohioans and too many people, frankly, across the nation, a notion developed that COVID-19 was just not something that impacted people less than 18 years of age, that this was a disease of older people. And what we've learned since the beginning of the pandemic is that's just not true. Not only, and we've outlined this in other press conferences, can otherwise healthy children develop very, very severe consequences, including the multi-system inflammatory syndrome of children that places them in the intensive care unit and causes severe inflammation of many body organs. Not only that, but now, as we're sharing today, we're actually seeing that children can have COVID-19 in combination with other viruses at the same time. And there's real concern as we're seeing more and more children landing in the hospital with these other respiratory illnesses that COVID-19 may actually be putting them in a less advantageous position. It may actually be complicating their other respiratory illnesses. So this is not the time to think that just because one is a child or less than 18 years of age or a young adult, that COVID-19 is not something that matters to you. It does. And that there are personal reasons for you to get vaccinated, not to mention the fact that not getting vaccinated really leaves you at risk for some avoidable disruptions to your own life, whether it's participating in sports or other extracurriculars, or of course your academic activities. So I think now is a very important time for all the parents of our vaccine eligible children to take them in and get them vaccinated.
Thank you, Dr. Vanderhoff. Our next question is from Marielle Carbone with WCPO.
Good morning or good afternoon, I guess. Now, doctors, this is either one of you could answer. Both of you guys had mentioned that with today's Pfizer approval announcement that you do expect that soon we'll see a vaccine for that 5 to 12 age group. What is soon? Is that a month? Is that the end of the year, January? What does that time frame look like? And is there any indication if it would be full approval for that age group or another emergency use authorization for 5 to 12?
This is Dr. Vanderhoff. I'll say that for the 5 to 12-year-old age bracket, the FDA has already signaled that their initial step with that will be the same as it has been with every new age bracket that has been added. They will likely begin with emergency use authorization and have that followed after a period of time with the process that results in full approval. And I just want to emphasize, and hopefully the approval today of the vaccine for ages 16 and older proves this point. But the process of full approval really has a lot to do with being able to demonstrate that the vaccine, in terms of issues that involve things like manufacturing, is in a position where it can essentially go into, the standard state of approval. Emergency use authorization still represents an approval for utilization, an authorization for utilization that reflects robust safety and efficacy review by the medical and scientific community. And I think that parents should have a very high degree of confidence when that authorization comes. Dr. Manning, what would you add as somebody whose institution is involved in the research?
I think you laid out the timeline and the standard expectation perfectly. And as I said before, we've had so many willing participants in these studies, and that data accumulates to allow for both the EUA and then finally the full approval once that last study dose has been given. I think it's 6 months out is the required timeline before full approval. So we can't wait. We will be so excited here at Cincinnati Children's when we can start offering vaccine to younger children.
Thank you, doctors. Our next question is from John Reed with Gongwer.
Thank you, doctors. Can you talk a little bit about the symptoms of RSV and these other illnesses as compared to COVID-19, and do they all spread basically the same way?
Thank you. I'll let Dr. Manning, as a pediatrician, field that question.
So interestingly, we've had a lot of experience with RSV, and so we're very familiar with the symptoms of RSV: cough, congestion, wheezing, particularly problematic in babies under 2, whose airways are smaller. They can have a very specific clinical presentation, so much so that our pediatricians here on staff and faculty and in training become very familiar very quickly with RSV and the lung disease that it causes, which we refer to as bronchiolitis. In contrast, COVID can cover a wide range of symptoms, and we've learned this over the past year. You'll all remember the very beginning, we thought, well, fever, that's the presenting symptom. And then we realized, well, no, it's fever plus some cough and congestion. And then it kind of morphed into, well, sore throat and a sinus infection. And there have been people who present with GI issues with COVID. So COVID is a very expansive set of symptoms and almost defies a good, very specific clinical presentation, whereas RSV, very familiar with it. We've seen it for a long time. So our clinicians feel pretty adept at distinguishing and identifying, here's RSV, here's COVID, and here's when we have to worry about one versus the other.
Thank you, Dr. Manning. Our next question is from Jesse Balmer with USA Today Network Ohio Bureau.
Hi, thank you. My question is, do you have a breakdown of what percentage of cases are COVID-19 versus RSV versus rhinovirus? What is leading to the capacity issues? Do you have a breakdown of that?
Just for clarity, you're referring to what's driving this wave of pediatric respiratory admissions to our hospitals?
Yeah, that would be great.
Yes.
Or if
Yeah.
you have a way of saying 20% of the beds are being taken up by RSV patients, or, something like that.
Yeah, what I can offer at a high level is that we're hearing from all of our pediatric hospitals that this unprecedented summer wave of these common respiratory viruses led by respiratory syncytial virus or RSV is impacting all of our children's hospitals. And that on top of that, they are seeing some increase in the number of COVID-19 cases. And so when you put it together, it really creates almost a perfect storm of activity at a time when our children's hospitals normally this time of year see very light volume of respiratory illnesses. And so we're not typically geared up for that in August. But in terms of more particulars, Dr. Manning, is there anything more you could share?
I can't break down for you specifically what percentage of beds are dedicated right now to what respiratory illness. I can say that certainly still the minority of our beds, fortunately, are filled with children who have COVID. That's still higher than we were a few weeks ago. I've said in some other forums that our number of COVID positive patients has tripled in the past few weeks, our inpatients, and it's quadrupled for our outpatients who've tested positive for COVID. We don't do a lot of testing for some of these respiratory viruses when the clinical presentation is very obvious, because it doesn't change the care that we're going to deliver. But I think it's safe to say that the minority of beds right now are dedicated to COVID, but that number is on the rise and steeply on the rise. The more children who are not in the hospital that get COVID, and that number has been dramatically increasing over the past few weeks, that will lead to more children who eventually do get hospitalized. And at the same time, we have children, and this gets referred to a lot, we have children who are hospitalized for other reasons, other serious reasons: bone marrow transplants, congenital heart disease, cancer and chemotherapy. And then they happen to be COVID positive. And as you heard somebody mention, you don't want to have to find out what COVID plus RSV is like in a baby. You don't want to have to deal with COVID when you're also dealing with another serious illness in a child. And so there are just so many reasons why we need to be doing everything possible right now to keep kids safe and healthy.
Thank you, doctors. Our next question is from Haley Nelson with ABC6 Columbus.
Thank you for taking my question. Hopefully you can hear me. I'm using a new system today. I'm curious, Dr. Vanderhoff, given the full FDA approval for the Pfizer vaccine, do you expect vaccination rates to go up in Ohio?
Well, I'm really pleased that, as I shared before, as we've looked over the last couple of weeks, we have seen rising vaccination rates here in Ohio compared to when we were looking at much of the depths of July. So I'm indeed optimistic that this announcement will add an additional layer of confidence for some of the folks who may have been on the fence and would hope that we will see more people rolling up their sleeves and getting the vaccine. You know, to me, this announcement by the FDA today was their further affirmation that these vaccines are outstanding, safe, and effective vaccines, and really removes any further excuse for any of us to hesitate on the basis of vaccine safety.
Thank you, Dr. Vanderhoff. Our next question is from Laura Hancock with Cleveland.com.
Hi, I was just wondering, kind of piggybacking on what Jesse was asking, what is the situation with pediatric hospitals in terms of capacity right now? I know that in some states, the RSV situation, such as in Utah, combined with the COVID situation, has made the pediatric hospitals there over capacity. I'm wondering, how close are we to that here in Ohio?
Well, I'll begin by saying that it's watching some of those scenarios play out in other parts of the country and in other parts of the world that has really led us to come here today to share information about, you know, where we sit here in Ohio at this time. I think that the good news is that our pediatric hospitals are reporting to me that while these are troubling increases and the hospitals are pressed by the volumes that they're taking care of, we are not yet at a situation like the ones that we're hearing in some of the states you just referenced. But we could get there. And we want to take every step we can to avoid that. And the good news is that we know what we need to do to help keep Ohio and Ohio's children's hospitals from ending up there. And that is vaccination for those who are eligible and application of the safety measures that have shown themselves to work so well, especially in our schools. And that relates to the masking, the distancing that we were just talking about, as well as good hand hygiene, attention to ventilation, et cetera. So Dr. Manning, what would you add to my answer?
You know, I would add that we are fuller than we usually are this time of year. You've heard a version of that already because of these respiratory viruses that have surfaced at an atypical time. So we're fuller than we usually are, but we're able to handle that. Apologies, my light went out. Hang on a second. We're fuller than we usually are, but we can handle it right now. But two things happen in the fall. One is that when children return to school, our rate of mental health admissions goes up. And so that adds to our volume of patients that we're taking care of on inpatient and our inpatient settings. And the second thing that happens in the fall is as children return to school and people move inside, we see more respiratory viruses. So as Dr. Vanderhoff alluded to, we are sounding the alarm a little bit in advance of that time period, because if we follow the trajectory of some of our southern neighbors, which we don't want to do, but if we do, we could be in a very dangerous position with regards to caring for the children of Ohio. Nobody wants to be an alarmist. I don't want to be an alarmist, but I also feel it's my responsibility to share the trends that we're seeing and to ask for help when we need it. And I feel like it's also our responsibility to just let you know what you can be doing to help us, which Dr. Vanderhoff has outlined so perfectly. So we're good now, but we can't promise you that we'll stay good. And we can't just hope. We talk a lot in medicine about how hope is not a strategy. I hope we don't get there, but I can't just rely on that hope. I have to ask for your help.
Thank you very much. Our final question today is from Kevin Landers with WBNS 10 TV.
Hello, this is a question for both of you. When do you think we'll reach the peak of Delta in the state? You know, how far away are we from a plateau?
Well, this is Bruce Vanderhoff. What I would say is that in my experience now, having dealt with this virus over many, many, many months, I don't think anyone can make accurate predictions about what the virus will do. However, what I can do is look at the trajectory of our numbers and look at what I'm seeing in other parts of the country and other parts of the world. And what that leads me to conclude is that the Delta-driven wave of COVID-19 will almost certainly be a wave. We will hit a peak of this if it continues to act in the way it's acted in other places. However, I've also seen when I've looked at those other locations that the kind of pattern we're seeing here in Ohio suggests to me that we're not approaching that peak. That what worries me is that we continue to see our numbers escalating day over day. And so I think what we need to do is take that very seriously, recognize that our healthcare infrastructure, while it is coping very well with the demands of the Delta wave now, could be overwhelmed, just as we're seeing in other parts of the country and the world where it has gotten overwhelmed. And that we as Ohioans can and need to take the steps that can help prevent that from happening. And those are the ones that we've been saying over and over here today. Begins with vaccination. Clearly, vaccination is our most powerful weapon against this virus and even against the current wave that we're experiencing. But it is supplemented by the other safety measures that we've talked about, masking, distancing, et cetera. So Dr. Manning, what would you add to my answer?
We spend so much time with very talented medical epidemiologists trying to answer that question. We would love to know when this is going to peak. And the reality is we don't know. We just see sort of a fairly steep line up right now based on the volumes that we've already seen. And so to that point, I would just reiterate what Dr. Vanderhoff said. We need to prepare for the worst, hope for the best. We need you to help us. We don't need gifts or donations. Well, we probably could always use donations, but we don't need pizza or dinners or to be called heroes. And we certainly don't need to be called zeros. We need you to help us by getting vaccinated and staying safe and wearing masks and washing your hands.
Thank you, doctors. That was our final question. Dr. Vanderhoff, if you'd like to share any final remarks, please feel free to do so.
Well, all I'll say is I think Dr. Manning said it very well, and I think she offered us about the best conclusion I could offer. So
Thank you all for joining us. Just a reminder to mute, and if you need permission to record or have a question, please indicate so in the chat. We are allowing a few more in from the waiting room, and we will begin shortly. All right, thank you all for joining us. Dr. Vanderhoff, I believe we are ready to begin.
All right, thank you. Well, good afternoon. I'm Dr. Bruce Vanderhoff, Director of the Ohio Department of Health. And once again, I'd like to thank you for joining us today. As you've probably heard, this morning, the White House outlined a plan to offer booster doses of the two mRNA vaccines, Moderna and Pfizer, to fully vaccinated adults 18 and older 8 months after their second dose of vaccine. They anticipate this will begin on September 20th for those Americans who received the first doses of the mRNA vaccines in the winter, including older Ohioans, those in long-term care facilities and healthcare workers. It's important to note, however, that this plan is still subject to the FDA's independent evaluation and determination of the safety and effectiveness of a booster dose, as well as the CDC's Advisory Committee on Immunization Practices issuing booster dose recommendations based on their thorough review of the evidence. Of course, at this time, we're also reviewing the data and awaiting the scientific guidance and determinations of both the FDA and the ACIP. Nevertheless, today, the U.S. Health and Human Services reaffirmed that the COVID-19 vaccines authorized in the United States continue to be remarkably effective in reducing the risk of severe disease, hospitalization, and death, even against the widely circulating Delta variant. Now, we need to remember that protection against severe illness and death, which the vaccines continue to offer very robustly, was in fact the original goal of these vaccines. Vaccines against respiratory viruses rarely protect against mild to moderate infections, as well as they protect against severe illness, because they're much better at inducing immunity in the lungs than in the nose, where respiratory viruses first infect our bodies. Also, our immune systems are very robust and very complex and include both antibodies as well as special cells known as B cells and T cells. Doctors generally expect levels of antibodies to most respiratory viruses to decline over time, even for vaccinated people. That happens against most bugs. But in most people, the vaccines against COVID also created reserves of B cells and T cells, reserves that recognize the virus and lie in wait even after our antibodies wane. Now, this means that while immunity against more moderate infection may indeed begin to wane, our protection against severe illness and death is much more likely to endure. Here in Ohio, we continue to see troubling increases in COVID-19 cases statewide, with more than 3,200 new cases reported yesterday alone. That's the highest since February. The Ohio Hospital Association has reported that statewide, 1 in 13 patients in the hospital are there with COVID, and 1 of 7 patients in the ICU is battling COVID. And as reported across the rest of the country, this continues to be the unvaccinated who are driving these hospitalizations. These statistics are worrisome and they clearly are the result of the dangerous and highly contagious Delta variant. Although we still have hospital beds and ventilators available for patients, as well as those facing other illnesses, the rapid spread of the threatening Delta variant statewide, especially in the context of our hospitals being very busy caring for patients with other serious conditions, brings heightened concern as reports continue to reach us from other states that hospitals there are beginning to turn away elective procedures and are even seeking to move patients to beds out of state. And of course, Ohio students are now preparing to go back to school, which adds additional concern about what impact that will have on our current trends. As Governor DeWine shared yesterday, Brevard Public Schools down in Florida reported that they started schools with masks as an option, and just 1 week later reported more than 1,000 students and staff in quarantine, with an additional 470 actual cases among their students and teachers. And when South Carolina's largest school district in Pickens County reopened without a mask requirement, in just 9 days, the COVID cases spread exponentially, with 168 students testing positive for COVID-19 and another 568 students and staff landing in quarantine. And they have shifted now, unfortunately, to a temporary virtual learning. And we don't want that to happen here in Ohio. Our goal is to keep our K through 12 students in school in person 5 days a week. In-person learning, we know, is very important for the cognitive, social, and emotional development of our children. And it can be conducted safely, even in the face of COVID-19, particularly when our schools are able to employ the layered prevention strategies, which include masking, social distancing, good ventilation, and good hygiene practices, along with vaccination of our eligible people. Last spring, these practices created a very safe environment in our schools. When school districts implement these same layered prevention strategies across the state, we're confident it will enable uninterrupted academic experiences as well as extracurricular activities for Ohio students. In fact, our K through 12 quarantine guidance is built around these layered prevention strategies. And when a school requires masking for everyone, regardless of vaccination status, they are also applying maximizing physical distancing of at least 3 feet between desks, and they have other documented COVID prevention practices in place, including things like hand hygiene. We have indicated that students are able to forego quarantine if exposed in the classroom. In addition, even if a school doesn't have such procedures in place, but the student or teacher exposed is either vaccinated or consistently wearing a mask, they also will be able to remain in the classroom with some additional masking and or testing recommendations, as long as they are not experiencing symptoms. Quite simply, by choosing to be vaccinated or choosing to wear a mask, even if not required by the school, the student or the teacher benefit. And they avoid a constant vicious cycle of quarantining and returning to the classroom over and over again. So adopt